Case 1, Mr. Johnson. My primary hypothesis is that he has lumbar spinal stenosis. My biggest clue comes from his subjective history taking. We know that prolonged periods of standing or walking bring on his symptoms, while sitting relieves his symptoms. From his outcome measures, we know that he can sit for any period of time. This aligns with spinal stenosis because in flexion, we maximize the cross-sectional area of the spine, and in extension, we minimize the cross-sectional area of the spine, which would impinge on the nerves. I would perform a neural exam, and I would expect the straight leg raise, Wells test, dermatomes, myotomes, and reflexes to come up positive for nerve symptoms. In active range of motion and passive range of motion for the quadrant test, I would expect to see that extension reproduces or intensifies the symptoms. He would also have limited hip extension, flexion is limited, and side bending is limited. In manual muscle testing, I would expect to see weakness of the hip flexors and abductors. My secondary and remote hypothesis would be SI joint dysfunction and lower back pain with motor coordination impairment, respectively. I can rule these out because we know that sitting relieves his symptoms, and I thought SI joint would be possible because it's load-bearing, but sitting is also load-bearing. And then the remote hypothesis we can rule out because he can sit for any period of time. To rule these both out, I would also do joint play, and for SI joint, I would do posterior pelvic tilt pain test, SI distraction and compression test, sacral thrust test, Galen's, and pain palpation. For both of these, I would also expect to see hypomobile lumbar segments, but if it's not there, we can rule them both out. Thank you.